again. Today, for those of you who weren't here last week, my name is Carlota Baptista. I'm a medical oncology resident in Portugal. And last week, we talked about the fundamentals of oncology and breast cancer. And today, we'll speak about colorectal cancer. It will be a shorter session than last week's one. Okay, so first of all, colorectal cancer is the most common type of gastrointestinal cancer. It's the third most common cancer in men and the second most common cancer in women. Does anyone want to guess what the two most common cancers in men are? Any guesses?
Lung and prostate.
Exactly. Yeah, perfect. So for women, it's easy. So it's breast cancer, and colorectal cancer comprises around 10% of all cancers worldwide. As it happens for most types of cancers, we have the sporadic variants and the hereditary variants. So most types are sporadic, around 60 to 65%, and then around 25% are hereditary. For the risk factors for sporadic colorectal cancer, as is true for instance, for pancreatic cancer, for esophageal cancer, and for gastric cancer, the Western lifestyle is linked with an increased incidence of these types of malignancies. Okay, so we have the obesity, the diet that is rich in red meats, and then in this specific type of malignancy, we also have the inflammatory bowel diseases. Okay, so patients with Crohn's disease and ulcerative colitis have an increased risk of colorectal cancer, and they have specific guidelines for screening as well. We think there's also a link with the gut microbiome. So this is something that is being researched at the moment, but we're not really sure as of yet what is the connection, but we think there might be something. Also, never forget about the age as a risk factor. So if anyone asks you about risk factors for most any other type of malignancy, age is usually a common risk factor. And around 70% of patients with colorectal cancer are more than 65 years old. Okay, it's very rare in patients under 40 years old. Then for the hereditary types, we have some syndromes that are linked with a higher lifetime risk of colorectal cancer. These are, for instance, the familial adenomatous polyposis coli and its variants like the Gardner syndrome. This is linked with a 100% lifetime risk of colorectal cancer. So these patients usually start screening around the age of 10, 12 years old, and they undergo colonoscopy annually. And most of them, at some point of their disease, will undergo a colectomy, okay, prophylactic colectomy. Then we have the patients with the Lynch syndrome. They have a 15 to 80% lifetime risk of colorectal cancer. And then we have some less frequent syndromes like the Turcot syndrome and the Peutz-Jeghers. For the screening, so this is one of those types of malignancies where we have a population-based screening. Always remember that even though we have the colonoscopy and the fecal occult blood test, the colonoscopy is always the preferred method, okay? So the fecal occult blood testing is only for those patients who refuse colonoscopy, okay? Why? Because it allows us to see the whole colon. It's both diagnostic and therapeutic, because if there are some adenomas that are detected or some other pre-malignant lesions, they can be removed. And if it's negative, it only needs to be done every 10 years. The fecal occult blood testing should be done when the patient refuses colonoscopy. It should be done annually and no later than every 3 years, okay? And nowadays we have this special type of fecal occult blood testing, which is called the fecal immunochemical testing, and it is more sensitive than the older methods like the GWAWAC. For the signs and symptoms, we already know about this. So it's the change in bowel habits, the blood in the stool, usually bright red blood, especially if it's a rectal cancer. But sometimes in the cases of elderly people that are usually very obstipated, it can also present with dark stools, something like melanas. And then the abdominal pain, the fatigue, the unexplained weight loss, the loss of appetite, but this is more common usually in more advanced stages and not so much in earlier stages, okay? There are also some patients who are living their best life and then they stop having bowel movements one day, then the other, and then they start having abdominal cramps, fever, they are feeling very unwell, then they come to the ER and they do a CT scan and they have a bowel obstruction. Okay, this is not so rare. Sometimes colorectal cancer can present like that, and these patients have to have emergent surgery. And it's usually a bad prognostic sign. So even if they have early stage lung colorectal cancer, they will have to do adjuvant chemotherapy after. For the diagnostic workup, so complete colonoscopy to assess where is the primary lesion and to do a biopsy. Then the laboratory workup, we need the complete blood count, the coagulation, the kidney function, the liver function, and the CEA. As we've talked in the previous session, the CEA is not very useful, as is true for most other tumor markers, for the diagnosis of colorectal cancer, but we know that post-operative levels higher than 5 are usually linked with a worse outcome, and they should be measured pre-op and then post-op and during follow-up to assess for relapse. Also for the patients who are undergoing chemotherapy for metastatic disease, we usually ask for the CEA every month to assess treatment efficacy. Then we need a CT scan with IV contrast. Remember that for staging and for the diagnosis of every type of cancer, we always do the CT scan with IV contrast. We will do a CT scan of the chest, the abdomen, and the pelvis to assess for distant metastases. And then the abdominal MRI can also be useful if we have some lesions that are detected in the liver by CT, but we're not really sure if it's an hemangioma or if they are metastases. So the abdominal MRI is better to assess this. The pelvic MRI is useful in the case of rectal cancer to assess what is the relationship of the tumor with the surrounding organs. Let's drink something. Then this picture, I think it sums up very well the staging of colorectal cancer. You can use it when then studying for your oncology exam. As we already know, the T stands for the extension of the primary tumor. And in the case of colorectal cancer, it has to do with how much of the bowel layers are invaded by the cancer. So the TIS is the carcinoma in situ, so there is no invasion. The T1 is when the tumor invades the submucosa. The T2 is when the tumor invades the muscularis propria. The T3 is when the tumor invades through the muscularis propria into the
Sorry, we can't hear you anymore.
I think you muted yourself by mistake. Oh, yeah.
Okay, can you hear me now?
Yes.
Okay, so until where did you hear?
Till T3.
T3, okay. So the T4A is when the tumor invades through the visceral peritoneum. and the T4B is when the tumor invades through the adjacent organs or structures, okay? Then the N staging has to do with how many lymph nodes, local regional lymph nodes are involved, okay? I will not, I don't think you have to know this by heart, but just know that it has to do with the number. And then the M0 is when there are no distant metastases, and then the M1A is when there is metastasis to one site or one organ without peritoneal carcinomatosis. Okay, so one site or one organ and no peritoneal metastases. The M1B is when there are metastases to two or more sites or organs and still without peritoneal carcinomatosis. And then the M1C is when we have the peritoneal carcinomatosis and also metastases to other organs. To make it easier, just remember that stages 1 through stage 2 is when we have any T with an N0, okay? So we have any extension of the primary tumor without any involved lymph nodes. Then the stage 3, and this is true for many other types of cancer, is usually when we have involved local regional lymph nodes, so it's an N+, regardless of the T. And then the stage 4 is an M1, regardless of the T or the N. I think it makes it easier to understand. Then, for the treatment, I will divide it into the stage 1, stage 2 and 3, so the locally advanced, and then the stage 4 or the metastatic disease. For the localized early stage disease, so the stage 1, the treatment is surgery, okay? And it's a slight different surgery depending if it's a colon cancer or a rectal cancer. In the case of colon cancer, the surgery usually be a hemicolectomy. It will depend on the side of the tumor, and the lymphadenectomy, and at least 12 lymph nodes should be removed. Then for the case of rectal cancer, we either do, depending on the location of the cancer, a rectal anterior resection or an abdominal perineal amputation. And the patients that undergo an abdominal perineal resection, this is a very mutilating surgery, and the patients will have a colostomy for the rest of their lives, okay? So as I will talk just in the next slide, for the rectal cancer, for the locally advanced disease, we usually do neoadjuvant chemoradiation. And if the patient has a very good response and the tumor clinically disappears, then they enter a watch and wait strategy. But I will tell you in the next slide how it's done. For the colon cancer stages 2 through 3, the treatment is with surgery, once again, and we can do adjuvant chemotherapy or not. The specific criteria for doing adjuvant chemotherapy are something that it's a bit more complex, and I don't think that you have to know it. Just remember that in stage 2, most patients don't need adjuvant chemotherapy after surgery, but some patients with high-risk features will receive it, usually 3 or 6 months, okay? It's not 3 to 6, so it's not very correct what I've written here. It's 3 or 6 months, okay? But most of them don't need it. This is different than stage 3. In this case, all patients will need adjuvant chemotherapy, and the chemotherapy that is given for colorectal cancer, it's nearly almost the same kind of regimens. So it should contain a fluoropyrimidine. We usually use either 5-FU or capecitabine. These are basically the same drug, but in different forms. So the 5-FU is an IV drug, and the capecitabine is in tablets. And we do it with oxaliplatin, okay? Because we know that if we combine these two types of chemo, we have a survival advantage in these patients, and they have a lower risk of relapse. Usually we do 6 months, but in some cases it can be 3, okay? So stage 2, Most of them don't need adjuvant chemo. Some of them will need it, those with high risk features. Stage 3 always need adjuvant chemotherapy with a doublet, with a fluoropyrimidine, with oxaliplatin. Then, the rectal cancer. So as I was telling you before, this is something quite different from colon cancer, okay? In these patients, we usually do neoadjuvant chemoradiation, okay? Because we want the tumor to shrink, because we know that these patients, if they go to surgery, they will have a very mutilating surgery, and some of them can have a colostomy for the rest of their lives. So we usually do the chemoradiation. We do the radiotherapy, usually is done over the course of 5 weeks, and the patient will do chemotherapy with a fluoropyrimidine, usually these tablets with capecitabine. Okay, it's a radiosensitizer. It allows the tumor to respond more to the radiation. Then we check what was the response to this treatment. If the patient had a very good response, a very good tumor regression rate, and we cannot see it on the MRI, by the digital rectal exam and the rectal ultrasound, these patients can enter a watch and wait strategy. The goal here is to prevent them to having to do abdominal perineal resection and having to be for the rest of their lives with a stoma. So we will do an active surveillance every couple of months. This has a specific schedule. We will do these exams, the digital rectal exam, the pelvic MRI, and the rectal ultrasound to check if there was.
You got muted again.
Yeah, we can't hear you.
Sorry, I don't understand why it's muting. You can hear me now, yes?
Yes.
Yes.
Okay, so what was the last thing that you heard?
That the treatment is watch and wait, and then you'd rather avoid the serious surgery regarding rectal cancer.
Okay, yes. So if the patient that have a good response, they will stay in active surveillance. If they relapse, we will have to go to surgery. If not, we will continue the watch and wait strategy with every couple of months doing the digital rectal exam, the pelvic MRI, and the rectal ultrasound. Okay. Do you have any questions about this part? Sometimes it can be a bit confusing for the treatment of locally advanced rectal cancer. Was it clear?
I have a question in
Yes. Had a question, sorry?
Oh, sorry.
Yes,
I said in the stage 1 after hemicolectomy, will you still do a stomy, or will you make a connection in between like the small intestine and the left colon?
Yeah, many patients will have a transit reconstruction. Yeah, and they will not need a stoma.
In terms of like outcome, is it better to have a stomy or to have that connection?
Well, in terms of the oncological treatment is the same, but for the patient is much better to have the transit reconstruction, okay? Because sometimes with the stoma it can be hard. Sometimes they will have a lot of diarrhea and will have some electrolyte disturbances. So for the patient, for the overall nutrition and so on, and even for their comfort and self-image, it's always better to have the transit reconstruction. So anytime that it's possible, the surgeons will do it, okay?
All right, thank you.
Okay, so then finally, for the treatment of stage 4 colorectal cancer. So we saw before that the treatment of locally advanced rectal cancer and colon cancer is a bit different, but for colorectal, stage 4 is all the same. So we usually divide it into 3 types. So the patients with initially resectable disease, okay, these are the patients with metastatic disease that we can sometimes cure. And the patients with potentially resectable disease, these are the patients that have metastases, but we think that with some chemo, we can then operate on them. And then the patients who have a very widespread disease, like this image here, if the patient has a lot of liver metastases, and that they also have peritoneal carcinomatosis, lung metastasis, it's clear that it's impossible, and no matter how much chemo you do to operate on these patients. So in the patients that has oligometastatic disease, so these are the patients that have few metastases, usually in the liver. We have more experience with operating liver metastases than other sites of metastases, but sometimes even lung metastases can be operated on. We can do one of two things. If we think the patient is a good candidate for surgery, if the disease is easily operated on, then we can do upfront surgery, and then we operate on the metastases and also on the primary tumor. Okay, we have to remove all of it. Doesn't make sense to leave the primary tumor in place and only operate on the metastases. Another strategy, and this is what is most commonly done in clinical practice, is to do perioperative chemotherapy. So we will usually do 2 to 3 months of chemotherapy, again, using the same agents that I told you before. Then we do a CT scan to check for disease response, and then we go to surgery. And then we do more chemo after. Usually we do a total of 6 months of chemo, okay? It depends, sometimes you can do 2 months before and then more time after. It really depends on the biology of the disease, okay? These cases are always discussed in the multidisciplinarity meetings, okay, because these are more complex cases. And we know that even though we're dealing with a stage 4 disease, the 5-year survival rates in these patients are up to 45%, okay? Then, in potentially resectable disease, we do conversion therapy. So this patient has a lot of metastases, but we think that with some chemo, we can take this person to surgery. So we start with chemotherapy, and we usually add an antibody that depends on the mutational status of the patient, and this is also something more complex that I don't think you need to know. So we usually do these doublets with the 5-FU with either irinotecan or oxaliplatin, or a triplet. But the triplets are very toxic. We use all 3 of these agents. These are only for the patients who are very young and very fit, okay? We usually do 2 to 3 months of induction chemotherapy. We then do a CT scan. If the response was good, we go to surgery, and then we can do or not adjuvant chemotherapy. It's not very well established. It's decided case by case. Finally, in unresectable disease, we only do the systemic treatment. There is no role for surgery here. The chemotherapy regimens that we use are the ones that I've told you before. So we do the chemotherapy. It always has to have a fluoropyrimidine backbone. So either 5-FU, the IV drug, or capecitabine, that are the tablets, which are combined with irinotecan. This is a regimen that is called FOLFIRI, or oxaliplatin, and this is a regimen that is called FOLFOX. It's done 1 administration every 2 weeks. And then for the patients, depending on the mutational status, we add an antibody, and this will increase the response of the tumor to the systemic treatment. Then these patients, we follow for the treatment efficacy. We do a CT scan every 3 to 4 months, and we also ask for the CEA monthly. The follow-up for the patients which were treated with curative intent is quite similar to the schedule that we use for other types of cancer. So we know that the risk of relapse is higher during the first 5 years after treatment. So during the first 3 years, we do more intensive monitoring. We have the clinical assessment and the CA. In my clinic, we do it every 3 months. We do a CT scan every 6 months, and we do a colonoscopy every 3 years, starting 1 year after surgery. If everything is well and the patient doesn't relapse, after 3 years to 5 years, we do the clinical and CA assessment every 6 months, the CT scan annually, and the colonoscopy, we still do it every 3 years, okay? And then after 5 years, it's the end of follow-up. The patient can be discharged from the oncology clinic, and is usually followed by their general practitioner, okay? Just know that around 30 to 50% of patients will relapse from colorectal cancer, but as I've told you during this session, we nowadays have many types of therapies, and we can even offer a curative intent to patients who have stage 4 disease. So it's very important that we follow these patients closely and we obey to these guidelines, okay? So to detect relapses early and act upon it. So this was all for today. Any questions? Anyone?
I have a question. At the beginning, you said that you test for colorectal cancer by colonoscopy primarily. In the case you use the fecal occult blood test, is there a way you can differentiate like the source of the bleeding? Because in that case, it could be from hemorrhoids or fissures. How can you know if it's from the polyps or?
Yeah, you can't know. So you have to do a colonoscopy after, always.
Okay.
Yeah. Anyone else? There are no other questions, I think.
Sorry, I have a question
Yes.
about last week's topic. I didn't understand, when would you do a lumpectomy? Like, what is the advantage compared to a mastectomy? Because anyways, the breast is not gonna look the same. So I don't know, I don't understand the point of just removing the lump and not the whole breast.
You know, it's hard if you haven't seen patients after a lumpectomy versus a mastectomy, but the cosmetic outcome for the patients is really different, okay? So nowadays we have really good surgeons with really great technique, so it's the breast will look very different if the patient have undergone a lumpectomy versus a mastectomy, okay? You can have really good cosmetic outcomes after a lumpectomy. And for the patients, and there is no survival advantage for doing a mastectomy in a patient who could have had a lumpectomy. And it's nowadays the surgeons are really great, and the breast will, in some patients, it will look like almost nothing was done there. Okay, it's mostly because of cosmetic reasons.
Can you still breastfeed if you have a lumpectomy?
Sorry?
Can you still breastfeed after lumpectomy?
Yes.
Yeah.
Thank you.
Welcome. So thank you all for coming, and I hope to see you next week for the last one.
Thank you. Goodbye.
Thank you. Goodbye.
Thank you.